Welcome to ESC TV, Barcelona. We're here at the ESC 2022 in Barcelona, and I'm joined here by my colleague Joo-Yong Hahn from Korea to discuss the results of the FRAME AMI trial. I am Stefan James, Professor of Cardiology, Uppsala University in Sweden. Joo-Yong, you presented your results yesterday. You were addressing an important clinical question, how we should identify lesions to revascularize in patients with multivessel disease suffering from ACS, STEMI or non-STEMI. Can you please briefly tell us about the results of your trial?
Yeah, we compared FFR-guided PCI versus angiography-guided PCI for treatment of non-infiltrated artery lesions. The primary endpoint of our study was a composite of death, MI, and repeat revascularization. So we enrolled 562 patients, and we randomly assigned these patients to the FFR-guided PCI group or angiography-guided PCI group in a one-to-one fashion. During 3.5 years median follow-up, the primary endpoint occurred less frequently in the FFR-guided PCI group versus angiography-guided PCI group. The benefit of FFR-guided PCI was mainly due to reduction in cardiac death and myocardial infarction, but there was no significant difference in terms of repeat revascularization between the two groups. So in conclusion, among patients with AMI and multivessel disease, FFR-guided PCI was superior to angiography-guided PCI for treatment of non-infiltrated artery stenosis in terms of all-cause death, MI, and repeat revascularization. That's the conclusion of our study.
So congratulations for having concluded a difficult trial during a very, very difficult period of time, during the COVID period. I want you to go back a little bit. Why did you decide to design and conduct this particular trial? What was the research question you were after?
Yeah, mortality after AMI is still high, especially in patients with multivessel disease. So previous studies demonstrated that complete revascularization, including culprit as well as non-culprit lesions, improves clinical outcomes. But optimal strategy to select targets of a non-infiltrated artery PCI has not been clarified so far. So the objective of our study was to compare FFR-guided PCI with angiography-guided PCI for treatment of non-infiltrated artery lesions.
Yeah, so that's an important clinical question. There is evidence that we should perform complete revascularization in patients with STEMI and multivessel disease rather than culprit-only revascularization. The question is how we should identify those lesions, which we should treat or leave alone. And you decided to try to look, is FFR superior to angiography-guided PCI in those non-culpritly related lesions? You started the trial during or perhaps before the COVID pandemic hit your institution and the world. And what happened with the trial during that phase?
Yeah, during the study period, COVID-19 pandemic occurred, unfortunately, and the hospitalization for AMI decreased by as much as 50% globally, and some centers halted the trials because of temporary unavailability of facility, cath lab, and lack of research personnel, and concerns about spread of COVID-19. So after the COVID-19 occurred, the recruitment became substantially slow. So in December 2020, we had to make a decision to terminate the trial prematurely.
And so how many patients did you plan to enroll, and how many did you eventually enroll?
The original target number of patients was 1,292 patients, but due to early termination, we enrolled 562 patients.
Yeah. So about half of the population you intended to enroll.
Yeah.
Yeah. So, which of course that I alluded to in my commentary yesterday is challenging for the interpretation of the results. The results were very impressive. You had a massive reduction in the primary composite endpoint of death, MI, and revascularization. You also had a large reduction in all-cause death and cardiovascular death, but also reductions in stent thrombosis. And you, as I commented on yesterday, may be possible to find because you limited the number of vessels to intervene upon and you reduced the number of stents by performing FFR. Still, I wanted you to discuss what are your potential interpretations of enrolling only half of the population you aimed for in terms of power and the results.
Yeah, the premature termination is a major limitation of our study, but given the observed event rate and the follow-up duration and the number of patients, the actual power of our trial to show difference in the primary endpoint between the two groups would be 95%.
Okay.
But anyway, our trial has not adequate power to detect a difference in mortality or stent thrombosis and so on. So the caution is needed for interpretation of our trial.
So there is a chance, likelihood that the mortality signal can be due to a chance.
As I mentioned, our trial did not have a power to detect a difference in mortality.
The other issue I wanted to discuss is with an underpowered trial, fairly small numbers, open label for obvious reasons, and including perimyocardial, procedural-related myocardial infarction in the primary endpoint. What do you think, how can a periprocedural MI assessment be affected by an open label trial with non-S elevation ACS and S elevation ACS with increasing troponins in all patients? And how did you deal with that?
Yeah, that's a very good question and comment. And our definition of MI was based on the third universal definition because when we designed our trial, universal definition 4 has not been published. But in ACS setting, the definition of MI was very difficult. So we exclude enzyme elevation only. Our definition for periprocedural MI or procedure-related MI quite strict. So 5 times more than upper normal ranges was needed, not enough, just needed. And the patients had to have ischemia symptom or ischemic ECG changes. And if needed, we examined the angiographic findings if it is really myocardial damage associated procedure.
Yeah, we shouldn't go into too much of detail, but you took serial biomarker measurements during the course of the procedure. And was that endpoint adjudicated by a central blinded committee, or was it reported?
We have an independent clinical event adjudication committee, and the members of CAC were blinded to the assigned group.
Okay, yeah. So that's well done then. I'm still in the context of a low power, open label, procedure-related MI. I still think that there might be a risk that there is an overinterpretation of the benefit. There's at least a chance, and there's also a chance with the low numbers that the mortality signal could be affected by that. But anyway, you show dramatic reductions in your pre-specified endpoints. There have been other trials addressing a similar kind of question and have had a similar design. Can you Can you comment anything about the environment of other trials showing slightly different signals?
So flower MI trial was conducted on the same topic, and there was a well conducted and relatively large sample size, but there are some difference between our frame trial and the flower MI trial. The first thing is follow-up duration. So in the flower MI trial, the follow-up duration was only 1 year, but in our trial, median follow-up duration was 3.5 years. The second thing is procedural success rate in the non-culprit lesions PCI. So I don't know the reason why, but in the flower MI trial, the procedural success rate for the non-culprit PCI was relatively low, lower than 90% in my memory. But in our frame trial, the procedural success rate for the non-invagulated artery lesions were nearly 100%. So I think that's two big differences between our trial and flower MI trial.
So the flower MI did not show a difference, and you did show an important difference.
Yes.
So in my comment yesterday, I suggested that perhaps we don't have the evidence to change the guidelines as of today. I think the question is still out there to find the best way to assess the severity of the lesions for revascularization in multivessel PCI. You have made an important contribution to try to address that question. What are your expectations of trials to come? There are ongoing trials and not reported trials that are also trying to address these questions. Can you give any thoughts on what you think the future will lead to?
Yeah, I know in my knowledge that there is a plan for a big trial in Canada group, perhaps. So for making a definite conclusion, we have to wait for the results from the large sample size.
Yeah. And do you think you tested FFR versus angiography guided PCI? Do you think there is a role for other imaging methods?
In our frame MI trial, the proportion of intravascular imaging use was about 30% for non-invagulated artery lesion. So I think that proportion of intravascular imaging was, could reflect the real-world practice in ACS setting.
Yeah. So I think I wanted to thank you for contributing to research during these difficult times, during COVID, that you're addressing important clinical questions, that you have succeeded to conclude, although prematurely stopped, but anyway conclude the trial. And I want to thank you for this discussion and the opportunity to discuss it for the ESC audience. And I would like to welcome you back to future ESC meetings to present more science for us and discuss those in the collegial environment. So thank you very much, and thank you to the audience for listening and tuning in to the ESC TV, and welcome back on other shows. Thank you.
Thank you.